Okay, then I guess we can start. Good evening, everybody, and welcome to tonight's EEL webinar. After summer break, which I hope that everybody enjoyed, we are back with a very interesting topic tonight, and we'll be discussing about medical therapies for endometriosis and adenomyosis. Before introducing our tonight's speaker, please allow me to share with you a short video of EEL's webinar sponsor, Gernot Richter.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter. Health is our mission. What does it take to make a med?
Okay, so now we can continue with our webinar. We thank again our sponsor, Gernot Richter, who's supporting the EEL webinar series for the second year already. And now it's our honor and pleasure to have with us tonight's speaker, Professor Hugh Taylor. Professor Hugh Taylor is the chair of the Department of OBGYN and Reproductive Science at the Yale School of Medicine in New Haven, Connecticut. He's also professor of molecular, cellular, and development biology at the Yale University. He's a certified, board-certified specialist in OBGYN and reproductive endocrinology. He did all his undergraduate training and residency in OBGYN at Yale. His postdoc training included a fellowship in reproductive endocrinology and fertility, as well as a fellowship in molecular biology, both at Yale. He has been the principal investigator on 15 National Institutes of Health grants and site PI or co-investigator of numerous additional NIH-funded projects. With more than 400 articles in leading medical journals, he will be giving a talk about the medical therapies for endometriosis and adenomyosis, and he prepared an excellent overview for tonight's EEL webinar. He's the immediate past president of the American Society of Reproductive Medicine, and he was elected to the National Academy of Medicine in 2016. Professor Taylor, thank you for having you here tonight, and we are looking forward to your presentation.
Thank you. Thank you for that very kind introduction, and glad that everyone took some time this evening to join me for this presentation. I see some of the names on the screen here are people that I know, so thank you for joining me. Today I'll talk to you about medical therapy for endometriosis. Just a disclaimer to start with, I do endometriosis surgery as well, and I don't want to say that surgery isn't a necessary part of endometriosis treatment. But today I'll be making a case for the appropriate use of medical therapy and talk to you about some of the background that justifies that, including some of our basic science that demonstrates the validity and usefulness of medical therapy. Now, I am not seeing my slides on the screen. Do I have to share my screen again, or can you see them?
No, we're not seeing them. You can share your screen now.
Let me try screen sharing again. Okay, can you see them now?
Excellent.
Good, okay. So, move to the first slide. So I think everyone in this group knows what endometriosis is, that ectopic endometrial glands and stroma that we think arises mostly through retrograde menstruation to settle in the peritoneal cavity. But I think this simple definition belies the complexity of the disease. Again, I think everyone here knows that sometimes you can get those classic lesions on the peritoneal surface. Sometimes you get the big endometriomas. Matter of fact, you can get multiple different types of lesions that may be subtle, and may even be missed. I think trained endometriosis surgeons will see the various presentations of endometriosis, but surgeries done outside of the setting of somebody with a real expertise in endometriosis or an endometriosis center may miss some of these more subtle lesions. The red lesions or the clear lesions or the white lesions. The black and blue lesions are usually what are seen, but some of these more subtle variants can be missed, or those peritoneal windows. So again, we may not always get or treat all the endometriosis. Again, setting the stage for use of medical therapy. Further, even when we do get all of the visible endometriosis, we know, and this is an older study, but there's follow-up studies that have shown this to be the case as well, that even normal appearing peritoneum can have microscopic endometriosis that is not uncommon. So even in expert hands, we may leave microscopic residual disease that over time can lead to recurrence. And again, I think justifies the use of medical therapy, even in the setting of surgical therapy. I think all of you also know that endometriosis stage does not correlate with pain symptoms. Whether we look at dysmenorrhea or non-menstrual pelvic pain or dyspareunia, no matter what stage of disease you have, you can see there really is no difference in pain symptoms. So you're starting to think that the lesions in the pelvis are not the whole story. Further, beyond that, we know that there are all sorts of symptoms associated with endometriosis other than just the pelvic pain. Pain is certainly the dominant symptom that we often see, but sometimes these patients present with infertility. And it's clear that women with endometriosis have all sorts of other issues and complaints. Fatigue is common, bowel dysfunction or pain is common, generalized inflammation, bladder dysfunction. There's also effect on the brain. There's increase in depression, increase in anxiety. And on average, women with endometriosis have a lower BMI. And now, as we're starting to look at these women as they get older, some of them have an increased risk of cardiovascular disease. This is associated with endometriosis as well. So it's not simply lesions in the pelvis causing pain. What you see in the pelvis really is just part of the disease. And when we think about endometriosis, we really need to start thinking of it as a systemic whole body disease and not just about a few painful lesions in the pelvis. And again, I think this justifies the use of medical therapy in the endometriosis. Again, not to dismiss surgical therapy, but I really believe medical therapy is a necessity to take care of some of these other issues. How does endometriosis have all of these far-ranging effects? Well, it's certainly not explained by Sampson's theory, which we know is retrograde menstruation, where lesions form in the dependent areas of the pelvis. But we know endometriosis can form in other areas of the body, the lung, the brain being sites that we not too uncommonly find endometriosis. Further, endometriosis was something we saw in men in the old days when men used high doses of estrogen for prostate cancer. So clearly it's not all from retrograde menstruation. Some years ago, we looked at bone marrow stem cells potentially as a source of endometrium and endometriosis. And we've published this some time ago, so I'll go through it fairly quickly. That we know that when we do transplant of male bone marrow into female mice and look at Y chromosome by FISH, when we look at endometrium or endometriosis, we can see here the red dot is the Y chromosome in the endometrium or endometriosis of mice, showing cells from bone marrow can travel to endometriosis. And I won't go through this today, but we did a lot of other studies that looked at identifying these cells truly as endometrial cells. We also found this in humans. This is a study, again, from some time ago, where we looked at HLA mismatched bone marrow transplant and showed in endometrium, you can see cells from the bone marrow donor ending up in the uterus, in the endometrium of these women who've had bone marrow transplant. So certainly bone marrow-derived stem cells can contribute to endometrium. Here's in our mouse model of endometriosis. Here, the red cells are the endometriosis cells. Or rather are the stem cells from bone marrow transplant. The top part of that graph above the line, and labeled A and B, is the endometriosis lesion. And you can see stem cells engrafting in that lesion. But not only that, the stem cells engraft outside the lesion, help to grow and expand the lesion, help to form new vasculature from endothelial stem cells that help form new blood vessels that feed the endometriosis, again, correlating with that frequent angiogenesis we see in endometriosis. And finally, these stem cells we can see in the circulation that are derived from the endometriosis. So not only are stem cells going there and creating endometriosis, but those stem cells then can leave the endometriosis and circulate throughout the body, seeding other areas. So again, this suggests that endometriosis truly is a systemic disease, that at least in some cases, especially those areas outside of the peritoneal cavity, outside of the pelvis, can be formed by stem cells that inappropriately differentiate. And this signaling from stem cells, their cell trafficking throughout the body, may cause some of the systemic effects. The other molecules that we've looked at for potentially mediating some of these systemic effects are microRNAs. MicroRNAs are small RNA molecules. They're encoded in the genome. They're transcribed, but they're not translated into proteins, but rather they're processed into these very small RNA molecules that typically bind to messenger RNA and block the translation of that RNA or lead to its degradation. So they generally block gene expression. So we asked if these were playing a role in endometriosis, and indeed, this is one slide from one figure from a paper we published some time ago that looked at the LET7 family of microRNAs. They're multiple. The blue are one with endometriosis, and the red are more aggressive variants of endometriosis, something like the deep infiltrating endometriosis. There's much lower levels of this particular microRNA in these lesions. But relevant to our therapy today, what I want to point out is that these microRNAs can leave the endometriosis lesions, travel in exosomes or as free RNA, and leave and get into the circulation, where they may play an important role in signaling throughout the rest of the body. A few years ago, we measured these microRNAs in the circulation of women with endometriosis, and we found that there are many that are greatly increased, some that are decreased. We even could use these potentially as a clinical test for endometriosis, a diagnostic. When we looked at a combination of these microRNAs in the women, we could find a training set that would perfectly predict endometriosis. Of course, when we went back and tested it on independent samples in the real world, not quite as good in this receiver-operator characteristic curve, but still high discriminatory value. But for today's talk, I'm not here to discuss a diagnostic. Rather, what I want to discuss is these systemic effects. We know very well from cancer biology that those microRNAs in the circulation aren't just there waiting for us to develop a biomarker test. No, they actually are taken up by other cells throughout the body and influence gene expression in these other cells. They have, in some sense, a hormone-like effect, remote effects from where they're produced. So we asked in endometriosis, what are these microRNAs that we found in the circulation doing? And the first thing we looked at here were macrophages. We know there's an increase in activated macrophages in the peritoneal cavity, that circulating macrophages are affected. And when we recapitulated the microRNA concentrations that we see in the serum of women with endometriosis in these macrophages grown in culture, and that is represented by the black bars here, we see an increase in TNF-alpha, IL-1 beta, IL-6, IL-8, all of the various inflammatory cytokines that we know are elevated with endometriosis. So at least this is one mechanism whereby endometriosis can lead to that systemic endometriosis by impacting cytokine production from macrophages. We also looked at body weight. You know, women with endometriosis on average have a lower body weight, lower body fat, lower BMI. And in this animal model, when we created endometriosis, we could show clearly this was cause and effect, that after inducing endometriosis versus a sham surgery, the mice stopped gaining as much weight and had a lower body weight. And then we asked how that might be happening. And first we looked at their adipose tissue. And you can see when, again, we mimicked the microRNA concentrations seen in the circulation of women with endometriosis. The adipose tissue, the fat, had changes in leptin, adiponectin, IL-6, hormone-sensitive lipase, all the things that would predict less fat accumulation contribute to that lower BMI. And I won't go through all the details, but we also looked at the liver in these animals where we created endometriosis. And not shown here, but the microRNAs are mediating much of this, but many of the enzymes in the liver that would lead to a change in metabolism and be predicted to lead to a lower body weight are changed in endometriosis, and some of this is driven by those circulating microRNAs. So there clearly is a metabolic effect associated with endometriosis. Again, one of those systemic effects. We looked at the brain and behavior. As I mentioned before, women with endometriosis have a greater incidence of anxiety and depression. They have central pain sensitization. They're more sensitive to painful stimuli. And here we created endometriosis in mice, and endometriosis is shown by the orange bars. We saw in endometriosis mice, we saw changes in gene expression of the brain, changes in electrophysiology in the brain, and this led to changes in behavior shown in the bottom half. We looked at anxiety in the mice, and within a few weeks, they were more anxious. We looked at pain sensitization, and by about 12 weeks, they showed greater pain sensitivity, and depression was seen within 4 weeks in these mice. So these systemic effects of endometriosis really are affecting the brain. It is not that these women are anxious and depressed, as too often we sometimes hear people describing them as anxious, uptight patients. No, it's really a consequence of the disease. Here in our animal model, we show that creating endometriosis actually causes these changes in the brain that lead to these behaviors: anxiety, depression, central sensitization of pain. Again, another systemic effect of endometriosis. And then finally, we've seen that correlation between endometriosis and women later in life developing atherosclerosis. Here we took a mouse model, again, created endometriosis, and then looked at atherosclerotic plaque formation. On the left, you see oil red O accumulation that's seen in fatty plaques in blood vessels. And this is the aorta. It's increased in endometriosis. And you can see on the right, the aortic lumen is smaller and the vessel wall is thicker, again, blocking blood flow, early development of atherosclerosis here. Another systemic effect of endometriosis outside the pelvis, and mediated by some of the inflammatory and microRNA changes that we discussed earlier. So I hope I've left you the idea that when we see a few lesions in the pelvis, we're really only looking at the tip of the iceberg. Endometriosis really needs to be thought of as a whole body disease, that it has an effect on the brain, it has an effect on blood vessels, it creates a systemic inflammation, it changes metabolism working through both adipose tissue and the liver. These are multiple manifestations that aren't really going to be treated just by surgical removal of the lesions in the pelvis. So when we think about endometriosis as a chronic systemic disease, we really need to realize that surgical therapy will target visible lesions in the pelvis. We may leave some residual disease that we can't see, and medical therapy really may be needed to treat all of the systemic manifestations of the disease. Main topic today is to go over medical therapy for endometriosis, and I'll spend the rest of the time talking about various medical therapies. I think most of you are probably familiar with the various approaches. The first-line therapies are typically oral contraceptives, with or without nonsteroidal anti-inflammatories. Progestins and other forms can be used. We don't have a Donagest in the US, but commonly used, I know, in much of the world. We use other progestins here, or a levonorgestrel-releasing intrauterine system. Second-line approaches were formerly GnRH agonists, although GnRH antagonists are rapidly taking over as the most commonly used second-line agent where available. Selective progesterone receptor modulators have shown some benefit, but unfortunately, liver toxicity has limited their use. SERMs and aromatase inhibitors can be used for endometriosis as well, but are not commonly used for such and aren't approved for such in the United States, at least. All of our medical therapy really works towards blocking estrogen. And we know endometriosis is driven by estrogen production, and either with using a GnRH agonist or antagonist, we block ovarian estrogen production. Androgenic molecules can do the same, or by using progestins. Not only do progestins have a direct effect on the endometriosis tissue, but they also counteract the effect of estrogens on the endometriosis. So in some sense are an anti-estrogen treatment as well. The oral contraceptives are clearly the first line treatment, and it's of course because of their progestin. It can be given cyclically or continuously, and I always prefer to give oral contraceptives in a continuous fashion to eliminate menses. If someone has dysmenorrhea, why have menses at all? And also every time that woman has menses, that retrograde menstruation that accompanies it may be continuing to feed the endometriosis. I think these work best for mild pain. They provide contraceptive benefit, but unfortunately there are some side effects of progestins, the bloating or breast tenderness, mood changes that some get with oral contraceptives or any progestin sometimes limits their usefulness. Other progestins are commonly used. This looks at medroxyprogesterone acetate. There's similar data for norethindrone. And again, I don't have Dynagest here because it's not approved in the US, but commonly used progestogenic substance throughout the world. It's very effective. And all progestins generally have a positive effect on endometriosis. Other means of progestin delivery include an IUD, especially for those with just dysmenorrhea, not as good for those with generalized pelvic pain. Progestin administered vaginally, especially for that in the rectovaginal septum. And depot medroxyprogesterone acetate is sometimes used, though I don't favor that because I find there's a lot of breakthrough bleeding that causes pain and less acceptable to patients. But of course, it is not only the progestin side effects that I mentioned, those bloating and breast tenderness and sometimes considerable mood changes, the depression or anxiety or irritability that comes with progestins that some are very sensitive to. But not only that, we know that endometriosis can be progestin resistant, either initially or develop resistance over time. And it's not a matter then of switching from one progestin to another. As I'll show you, what happens is really they have lower progestin receptors. This is a study published a few years ago with Valerie Flores when she was here working with me at Yale that shows if you look at those who responded to a progestin therapy versus a non-responder, on average, they have a much lower level of progesterone receptor. So they don't have the receptor. They're not going to respond to progestin. It doesn't make sense to switch from one birth control pill to another. If the problem is absence of progestin receptor, a different progestin won't really be effective. Matter of fact, in this study, when she looked at those with very high progestin receptor levels, 100% of them responded to a progestin-based therapy. And when she looked at the other extreme, those with very low levels, very few, here 6% responded to a progestin-based therapy. So it doesn't make sense to switch from one to another. For many women, this is progestins are a relatively easy and inexpensive therapy, but we know that maybe a third of them will either have or develop progestin resistance. Androgenic agents like danazol work well. Again, this Cochrane review showing efficacy, but I don't have many takers. Patients are afraid of that potential acne or hair growth or androgenic side effects. So I have very few patients who really want to use this agent, despite the fact that medically it works quite well for endometriosis. But despite endometriosis sometimes being progestin resistant, it's always estrogen dependent. And we've traditionally used as a second line for those who fail progestin-based therapy, a GnRH agonist to induce a pseudomenopause. Complications included bone loss and the vasomotor symptoms, but we've used add-back therapy. either norethindrone alone, which is FDA approved for use with a GnRH agonist in the United States, or a combination of estrogen and progestin therapies. Good data from the old days. Again, GnRH, this was from Leuprolide, that giving add-back therapy prevented the bone loss, as can be shown here. Here's a low-dose estrogen with norethindrone. Group C, you see there's no bone loss. And when we look at pain reduction, you can see at 6 months and again at 12 months, in those groups with the low-dose estrogen, the dysmenorrhea scores remained low. So use of add-back did not in any way diminish the efficacy in the treatment of endometriosis-related pain, but did eliminate the hot flushes and maintain bone density. So again, very effective. Now, of course, the emerging therapies are now the GnRH antagonists. We've had these available in the States for some time now. They work a little differently than the agonists. First off, they're oral, so our patients like them rather than having to get those depot shots. But with the agonist, you have to initially stimulate the receptor to get that, to get eventually a desensitization and downregulation. But that comes with an initial stimulation and the so-called flare effect, where the receptor is stimulated, you get an outpouring of estrogen and sometimes exacerbation of symptoms. The GnRH antagonists immediately block the receptor. Not only that, you can titrate the dose. With an agonist, you really need to fully stimulate every receptor to get them to downregulate. It's an all or nothing response. With a GnRH antagonist, since it directly blocks the receptor, you can give a little bit and partially block the receptor. You can give a lot and block the receptor completely. But there's no flare effect. It's an immediate suppression of ovarian steroids. It doesn't deregulate or desensitize the receptor. So it is immediately active within 24 hours or so. You can get suppression of estradiol levels and also immediately reversible. So faster and easier than the old GnRH agonists. Patients like them a lot better, again, because they're oral and they're not committed for months. And if somebody's thinking of pregnancy in the near future, you can easily reverse it. I'll go through the studies we published looking at elagolix. This was the first GnRH antagonist to be approved for use in endometriosis, approved initially in the US. Not available everywhere, but this was the first GnRH antagonist that we used. This is the study we published back in 2017. This two studies, actually, one conducted in North America and one conducted outside of North America. And this looked at women with endometriosis, had to have been surgically diagnosed, and importantly, had to have had moderate to severe dysmenorrhea and also had non-menstrual pelvic pain. So these were not the ones with mild pain. They had to have at least moderate to severe pain to enroll in this trial. After a washout period to get rid of any other hormone therapies, if they were on any, they were followed for 2 months to get baseline pain measurements and then randomized to receive either placebo, low dose of the elagolix once a day, or the twice a day high dose. You can see the results are shown here. Again, the placebo is shown on top. There's a little bit of a placebo effect. The low dose elagolix is shown in the middle and the high dose on the bottom. Now, the pain here was measured in a scale from 0 to 3. No pain, mild, moderate, or severe pain. And remember, to enroll, women had to have moderate to severe pain. So the baseline score here was 2.2. Again, 2 being moderate, 3 being severe, between moderate and severe. Notice at the high dose of elagolix, you see a drop of almost 2 points. So these patients were really quite comfortable. Most of that pain was eliminated at the high dose. Frankly, I used the lower dose for those with milder pain, not the ones enrolled in this trial, but those with only milder pain where maybe they're having side effects on an oral contraceptive or for some reason cannot tolerate it or resistant to it, but don't have the severe pain. For those with severe pain, I tend to like to use the higher dose of the elagolix. This looks at non-menstrual pelvic pain, exactly the same thing, some placebo effect. The low dose works a little bit, the high dose works better, at reducing pain substantially. This is an extension study. The initial data was at 3 and 6 months, but was followed out to a year, and you can see sustained benefit, even a slight improvement over time beyond 6 months. So really lasting efficacy. The side effects are exactly what you'd predict. This medication was not given with add-back therapy, so there were no serious side effects, but hot flushes were more common in those with treated with elagolix, whereas as were headaches. But fortunately, the majority of hot flushes were mild in each treatment group, and the discontinuation rate due to hot flushes was less than 1% in the low-dose group and less than 3% in the high-dose group. This is very different than what we saw with the old GnRH agonists, where there was huge dropout rates. And again, importantly, this was given without add-back therapy. If somebody's having hot flashes, there's no reason why you can't separately add add-back therapy to this regimen, treat them just like anyone else with having estrogen deprivation-driven hot flashes. So I frequently will do that if I'm using this agent. The responder rate, a little different way to look at this. We saw the amount of pain reduction on average, but how many people really had not only a statistically significant, but a clinically significant decrease in pain, that the patients thought it was meaningful and it reached statistical significance. Dysmenorrhea, you can see at the high-dose elagolix, about an 80% reduction in dysmenorrhea, or 80% responder rate, meaning 80% roughly of the patients had a clinically meaningful reduction in pain. Non-menstrual pain, about 70%. Dyspareunia, always harder to treat, but about 60%. So again, the majority of women had considerable improvement using this drug. I want to show you another drug, relugolix, combination therapy, which is now available in the US and in Europe. Originally approved for treatment of fibroids, but it's the very same regimen and dose that is used for the treatment of endometriosis. Importantly, this drug is given in one tablet with estradiol and norethindrone built in. So the add-back is built in. And unlike the elagolix, which required twice-a-day dosing to get high efficacy, this is once-a-day dosing. It's got a longer half-life, so more patient-friendly in that sense. You see the responder rate in the two trials here for dysmenorrhea, about 75%, and for non-menstrual pelvic pain, again, the two different trials done, about 60% on average. So similarly effective, and again, with the built-in add-back therapy, very patient-friendly. Importantly, this shows, again, some of the numbers that I just showed you, the 75% responder rate for dysmenorrhea and non-menstrual pelvic pain, about 60%. But again, with the add-back therapy built in, we see minimal bone loss, less than 1%, clinically not significant bone loss. So again, prevents the hot flushes, prevents the bone loss, very effective once-a-day therapy using a GnRH antagonist. I want to just go over a few things that we're doing in the laboratory now that might be future targets or future therapies. We really do still need agents that might be fertility sparing. All of the agents that we discussed earlier really reduce fertility or contraindicated infertility or act as contraceptives. We also really haven't targeted specifically the inflammation with endometriosis. And I think future therapies, it'd be nice if we have some that are fertility sparing, and we really need to think about targeting the inflammation. MicroRNAs that I've shown you are driving some of that inflammation and driving lesion growth. There have been things that we've targeted in animal models. And I'll show you some anti-inflammatories, repurposing some drugs that may be used for inflammatory conditions. This is in a mouse model where we used inhibition of microRNA 451, one of those that was quite elevated in endometriosis. And we show that when we treat the mice with this, with inhibition of that 451, we get a nice reduction in lesion size, still cycling, no drop off in hormone production. Here's LET7, another one I showed you is decreased in endometriosis. here in a mouse model, when we give more LET7 and increase LET7 in endometriosis, we similarly get a shrinkage of lesion size. But importantly, we also see a decrease of many key drivers of endometriosis, including a decrease in the inflammatory cytokines, this decrease in estrogen receptor alpha and beta, decrease in aromatase, and the graph shows you on the top a decrease in NF-kappa B expression too. So dampens that inflammation, not only shrinks the lesions, but dampens that inflammation associated with the lesions. Finally, here we show work with tofacitinib. It's an agent that's been developed that alters STAT3 signaling and used for arthritis. This also leads to endometriosis regression in our mouse model. You can see the lesions shrink with treatment with tofacitinib. Not only that, the adhesion scores are decreased as well. And we look on the right, you can see again that it definitely decreases JAK-STAT signaling, same way it does to treat arthritis. That's a key component of endometriosis growth as well. So targeting that pathway seems to be very effective. So we may be able to repurpose some drugs that are used for things such as arthritis and ankylosing spondylitis, which this drug is used for endometriosis. Also, we tried to block some of that stem cell migration that I showed you feeds the endometriosis. The cytokine CXCL12 recruits stem cells into endometriosis. And when we block that receptor, the CXCR4, the CXCR7 receptor, it's a busy slide, but I'll point out just the top couple of pictures of the lesions. They were considerably decreased when we block that stem cell migration into the lesions, another potential therapy for endometriosis. And finally, I'll show you last a molecule composed of factor 7 light chain fused to a IgG. So this binds tissue factor, which is aberrantly expressed in the blood vessels of endometriosis. So it really targets that angiogenesis and aberrant blood vessels we see in endometriosis. So when this conjugates bind, then these cells are targeted for immune destruction. We tested this not only in a mouse model, but in a baboon model, and showed that we could get regression of lesions in the baboon model, especially the red lesions that are the more vascular, fresh lesions that might be much more amenable to this ICON treatment. So multiple new ways that I hope will be treating endometriosis with medical therapy in the future that, again, may reduce inflammation, that may target the angiogenesis, that may be something, we even be possible, some of them to be used in the infertile population to enhance fertility. So I'll summarize by saying endometriosis is a systemic disease, and that systemic nature may explain some of these extensive symptoms that are often associated with endometriosis. All of these symptoms beyond the pelvis that I showed you earlier. And we know that stem cells and microRNAs and generalized inflammation are some of the mechanisms that mediate these effects very remote from the lesions. And when we talk about medical therapy, well, surgical therapy will treat that local disease in the pelvis. Medical therapy may be needed to treat all of these other various systemic manifestations. Progestins are still the first-line treatment for endometriosis, but now we have some much more user-friendly molecules that are second line. Instead of what used to be GnRH agonists, the GnRH antagonists are rapidly becoming second-line therapy where they're available, and maybe even used initially as a first-line therapy for those who've had progestin-related side effects in the past, or those who've failed progestin therapy in the past, where we know they'll have progestin resistance. This is fairly common. But again, because they are oral, because they are rapid onset, there's little to be lost from trying a GnRH antagonist, certainly as a second-line therapy, but even potentially as a first-line therapy today. I tend to use these, again, if there's any history of mood changes or side effects on a birth control pill in the past, or if endometriosis has progressed while someone was on a birth control pill, certainly switch them to a GnRH antagonist now as my second line, as these are becoming more and more available worldwide. I'll end there and just acknowledge people in our endometriosis center and my laboratory for the work that you've seen here and the NIH for their funding. Thank you very much, and we can open it up to discussion.
Thank you very much for the excellent overview. We are having already a couple of questions, so please let me start with the first question in our chat box. It's coming from Evgeny Bayev. So he's asking, what if the patient's age above the range? No, what's the patient's age above range where you would consider not to recommend any endocrine therapy after a total hysterectomy with complete endometriosis excision?
Where I would not recommend therapy. I mean, if you've done a hysterectomy and oophorectomy, so that someone's not, you might normally give them unopposed estrogen. Again, without a lot of data to support it, but I typically give them an estrogen-progestin combination hormone replacement therapy, but for about a year, and then switch them over to estrogen alone. If you haven't done an oophorectomy, which I think is what you're suggesting, sometimes we see endometriosis becoming less aggressive in the 40s. I often have a long discussion with patients about that. If we've left the ovarian function in place, if they're younger, I will still continue to recommend medical suppression. If they're in their 40s, I will have that discussion with the patient. Generally still recommend some sort of medical suppression, and potentially less aggressively than I might have otherwise. But I will often give the patient the option of not using medical therapy if they're well into their 40s, but always warn them that if they feel like their endometriosis pain is coming back, that we get on endometriosis therapy, medical therapy, very quickly before it progresses to the point where she needs another surgery, or perhaps it's less readily controlled. So have that extensive counseling with the patient, but somewhere into the 40s, if they want to avoid medical therapy, I'll let them. Some of it depends on how much endometriosis you found and how aggressive it looked at the time of the surgery as well. If they have fairly extensive disease where you know they're still at risk for recurrence, I'm much more likely to put them on a medical therapy versus those where you don't find endometriosis, or mostly the older scarred lesions and not the newer, fresh, clearer red lesions where they're actively growing and proliferating. So I think that's a judgment call. I don't think it's a clear and simple answer. But I think basing it on your findings at the surgery is probably the best basis for that discussion with your patient.
Thank you very much. Yeah, I was about to say that probably the key word in this question was hysterectomy with complete endometriosis resection. However, I remember one of your first slides where you wrote that in 25% of cases, you have a normal peritoneum where you still might find endometriosis lesions. So maybe these are the cases where it makes sense to offer some of the patients hormonal treatment even after you perform the TLH with complete endometriosis.
I think we have to know that even the very best surgeons among us are not going to get all the endometriosis. There is microscopic disease that generally endometriosis probably starts as microscopic lesions that we can't see, that will progress over time. And we know there's a fairly high recurrence rate after surgeries in general. So I think we're probably always leaving a little endometriosis behind, and why I think medical therapy makes sense even post-operatively.
All right, so from Germany, we move to Turkey, and Professor Ahmet Kale has a question regarding the clinically progestin resistance in patients who are given progestin drugs. He's asking if this is the way to understand clinically progestin resistance in patients who are given progestin drugs. And the second question regarding to progestin resistance is about the therapy options of changing the progestin drugs, or if you have any other methods to overcome this.
Yeah. So as I showed that we believe that much of this is due to reduced progestin receptor. There are some other variants where there's post-translational modification of the receptor so it doesn't respond as well. And sometimes giving massive amounts of progestin can overcome progestin resistance. But switching from one progestin to another, when there just isn't enough receptor there as the bottom line, doesn't make a lot of sense. So if they haven't responded to a progestin, including that in an oral contraceptive, that's when I usually am going to a GnRH antagonist these days. Again, now that we have a nice oral medication that's relatively easy to use and that is highly effective, I find that I move to that quickly when I don't see a response to a progestin, or again, in somebody with a history of developing endometriosis on a birth control pill for contraception, or who took it for contraceptive reasons in the past, and they had problems, headaches, mood changes, irritability, or depression, or they get breast tenderness or bloating. I quickly move them on to a GnRH antagonist that now is my second line.
Thank you. Well, we've been collecting some questions, so let's see if we manage to get all of them. So the next one is regarding Ahmed Namazov's experience in Israel with elagolix. So he's telling us that they've noticed that they have better results with elagolix in patients who are not having only endometriosis, but also other uterine disorders like myoma or adenomyosis. What's your experience with that?
So I've had a similar experience. The adenomyosis responds very similarly to endometriosis, quite effective for that. Fibroids or myomas generally take a slightly higher dose, and the FDA approved dosage for elagolix in the US is 300 twice a day rather than the 200 twice a day for endometriosis. It generally requires a little more profound repression. And the relagolix dose that is available treats both similarly gives you a suppressive effect that's similar to the very high doses of elagolix. For the fibroid dose of relagolix, of course, the only dose available of relagolix for fibroids, for adenomyosis, for endometriosis has the add-back built in. The elagolix, again, 3 different doses. The lower 2 for endometriosis do not have add-back. The higher dose for fibroids has the add-back built in. They always get more severe hot flushes. But you really need that higher dose and more complete suppression to treat fibroids more than you do for endometriosis.
Thank you. Yeah, so as you were saying in your presentation, some of these products are FDA approved in the US. Some of them are not approved in Europe, or at least not in all European countries yet. I know there's work in progress on that. So then we're moving to the next question from Yana Rakova. So she's asking that there's a recommendation to perform bone loss tests after 52 weeks. And her question is, what if there's a mild osteopenia in a patient after such a time, and if this is irreversible? What would be your approach to that?
Yeah, well, if it's very mild and it's within this normal for the age, I don't worry about it so much. If it's or I follow it closely. If it does change significantly, and if I think I'm going to keep somebody on for a long time, sometimes I'll get a baseline scan, because more likely it was there before the patient started the drug. So if I think I'm going to keep somebody on it for years, I'll often do a baseline DEXA scan so I can look for a change after a year or two. Because the most common reason somebody has low bone density is because they did before they started the drug. But for those who have a real change on the drug, I will take them off. And of course, I think, it's a little calcium, vitamin D is always a good idea for every young woman in this age range, but certainly can be recommended to do with these drugs as well.
Thank you very much. Now our EEL's president, Harald Krentel, couldn't make it. He's ill and he's, let's say, voiceless.
Sorry.
So he's been bombing you with a couple of questions. So he's asking you if surgery should be the third line after progestins and antagonists. He's also asking if we should offer antagonists before the surgery, or in other words, where is the place for the surgery in your opinion, also considering the fact that deep endo lesions are not progressive in most of the cases, as we've seen in the latest papers which have been published the first part of this year.
I generally do use surgery as a third line. Now, there will always be adhesions, scarring, fibrosis that no medication will touch. And there are some endometriosis that just is aggressive and needs to be treated surgically. So there's always a role for surgery. But I find I typically use a progestin as a first line, often in an oral contraceptive. If that doesn't work, knowing that progestin resistance is common, I will generally go to a GnRH antagonist. And if that fails, then I will go to surgery. And often we'll find that there's adhesive disease or something causing that pain. Now, of course, if you see, scarring, or, you feel an ovary that's fixed or scarred, or you feel a uterus that's immobile and deviated to one side, and there's going to be dense adhesions, you might want to think about surgery sooner, because no medical therapy is going to treat the inflammatory consequences of longstanding endometriosis, or the deep infiltrating endometriosis that's caused scarring and fibrosis in the area around it. Most of the medical therapies are very good, and the GnRH agonists and antagonists are very good at suppressing the active growth of endometriosis, but obviously not repairing the damage that's already been done. So there's selected cases where I would move to surgery much, much earlier, where I think that may be the case that this is that there's significant scarring or things that medical therapy won't touch. But as a general rule, I like to go to progestin, GnRH antagonists, and surgery after that.
Thank you. Dr. Yana Rakova is coming back to you with one more question. So she's asking, for how long would you consider leaving a perimenopausal patient on relugolix therapy, as we plan long-term management of the patient, and we don't know when she's going to be in the menopause.
Yeah, so I use these drugs that I haven't been out on the market for that long, so nobody's used them extensively for a very long time. But we have people who are on the old-fashioned agonist for many, many years. In the United States, the FDA has approved these drugs with the relugolix combination therapy with the ADVAC for 2 years, or the low-dose elagolix, where some endogenous estrogen is still produced. It doesn't give you a complete suppression for 2 years. I use it well beyond that time, and I don't have a time limit. I will check a bone density. That's really the only long-term concern. I will follow bone densities regularly if I'm going to keep somebody on it, especially if I go beyond the FDA recommendation. But I do not have a stopping point or a fixed number of years where I say someone cannot be on these agents. I find it's often hard in the US to get them paid for beyond that 2-year window, but I won't stop them if possible.
Thank you. What was your experience with letrozole? Is there any place for this treatment? What's the approach in the US regarding this therapy?
Well, we don't use much letrozole. Obviously, you need to use letrozole with something else, or it will stimulate, the hypothalamic pituitary axis, more FSH production. We use letrozole for ovulation induction. You really need to use it with something that suppresses the hypothalamic pituitary axis. And so you're using it already with a progestin or a GnRH agonist antagonist. So I find that there's not a lot of value if you're already suppressing that axis in that way. Again, there can be some aromatase production in the endometriosis itself, and on some instances it may be helpful. I use it as an adjuvant therapy when somebody is not responding to a GnRH antagonist and who really doesn't want to have surgery, I might give it a try. But to be frank, I have not had tremendous success with it.
Thank you. Again, Harakanta is coming back to you, asking about your experience regarding the use of antagonists in patients with adenomyosis.
Yeah, so again, not been carefully studied, although we have seen in some of the studies that were done for fibroids when patients had concomitant adenomyosis that it actually responded quite well. The studies weren't designed for that. In my own experience, yes, we use it for adenomyosis. It responds quite well to the GnRH antagonists, as you might expect.
Thank you. Now, one of the last questions, is there a cause and effect relationship between endo and chronic diseases like asthma, allergies, or do you think it's just a coincidence?
No,
And if yes, which one leads to the other?
I think it's a little more than a coincidence. I think there's some underlying genetic defects that probably are responsible or exacerbate both. But, you know, asthma, for example, is an inflammatory disease, and we know endometriosis increases inflammation. When you get inflamed, you're more likely to have asthmatic attacks. And some of these other autoimmune or inflammatory immune-mediated diseases are going to be worse if you have something that's exacerbating your immune system. And we've proven in carefully controlled animal models that creating endometriosis does lead to whole body inflammation. So I think there is a causal relationship. It's not something that we haven't quite proven yet. We haven't looked at asthma and some of the others, but certainly everything we've looked at, and I showed you many diseases there that are more common in women with endometriosis, we've been able to prove a causal effect that the endometriosis actually causes exacerbation of those diseases, and some of which are inflammatory diseases. We showed that direct result of the microRNAs increasing inflammation. Atherosclerosis is a classic inflammatory disease, and we've seen that correlation in epidemiologic studies, and people have said maybe we do too many hysterectomies, oophorectomies, or maybe it's the medications we give that are exacerbating the atherosclerosis. Well, no, in our mouse model, we showed they were identical in every way except the endometriosis, and it led to increased atherosclerosis. Without lipid changes, by the way. It was more from the inflammation created by the endometriosis. So this inflammatory milieu that's created by the endometriosis, I think, affects multiple other organ systems. And we haven't looked at some of the ones you just mentioned, but I'd be fairly confident that the endometriosis is exacerbating some of these.
Thank you for the thorough response. Meanwhile, we have another question. To say unresponsive to one form of therapy, what is the duration of that therapy? So when can we talk about unresponsive after how long?
I like to give them about 2 menstrual cycles. I want to see about 6 to 8 weeks. I expect to see some improvement. Again, you may get continued improvement up to a year. I showed you some of those long-term studies with elagolix that showed pretty continuing decrease in pain for about the first 6 months, and then even a little bit further decrease over the next 6 months out to a year. So I don't expect the pain to be where it will ultimately be at the end of 6 to 8 weeks. But I'd like to see 2 menstrual cycles, see if we've really suppressed or eliminated menses, and a couple of cycles where we know about if we haven't eliminated menses, where we know about the dysmenorrhea. But I expect substantial improvement, not 100% of where they'll end up, but substantial improvement within 6 to 8 weeks. So not the kind of thing where you say, take this birth control pill and come back in a year, obviously. But I usually schedule them a follow-up appointment 6 to 8 weeks later. And if they haven't noticed considerable improvement, not complete resolution, I'll give them some more time to hopefully get further resolution. But if they haven't shown considerable improvement by 8 weeks, I will consider them a failure and move on to next line therapy.
Thank you. I think that was a clear answer, 6 to 8 weeks. Next question is, are GnRH antagonists still a choice for teenagers and young adults?
Yes, I mean, there's always some concern about estrogen deprivation in this group and timing around puberty, but and they're not approved in the US for that population. So I'm a little more hesitant, but I do use them in teenagers who failed other therapy and have significant pain. I think they're still appropriate. Not approved, that's off-label, but not approved for that, not thoroughly studied. So I'm more careful about following their bone density and using them a little more cautiously, but I will use them. I mean, we know how terrible this disease is and how much pain it can be and how debilitating it can be. We've all seen those patients who, can't go to school and are just really crippled, and their life is so horribly affected by this disease that certainly even using something that's not thoroughly proven and studied is worthwhile in those more severe cases.
Thank you very much. We have another question from Dr. Karimova regarding the new treatment with azoprisnil, a selective progesterone receptor modulator.
Yeah, I mean, I think there's some benefit to azoprisnil and some other selective progesterone modulators are effective. There's some concern about taking them off so you don't get these endometrial changes. There's still some need for breaks for bleeding. And again, the selective progesterone modulators have just gotten such a bad name because of the liver toxicity. Although not common, I think that's the concern that's limited enthusiasm for development of the selective progesterone receptor modulators.
Thank you very much. So I think we've reached our 1 hour, and if we don't have any further questions, okay, so there's another question. How are you going to treat chronic diseases like atherosclerosis by suppressing estrogen?
Well, it's not suppressing estrogen. We're really trying to suppress the endometriosis, which is causing the inflammation that leads to the atherosclerosis. But I would do that with estrogen add back. We know in menopausal women, it doesn't take much estrogen to see cardiovascular benefit in the younger, newly menopausal women. Again, I think we know now from some of these studies, Keeps and Elite, that newly menopausal women given some low-dose estrogen, you can prevent progression of atherosclerosis. Giving it much later in life is not effective and may actually exacerbate atherosclerosis. But it doesn't take much estrogen to keep a vessel healthy. It's like bone and hot flushes. These remote organs far from the pelvis are designed in some sense evolutionarily to be healthy at very low estrogen levels, not to fluctuate up and down through the menstrual cycle, not to be in distress at the time of menses when estrogen levels fall very low. High doses of estrogen or higher estrogen naturally produced is what drives endometrial growth. It takes quite a bit to drive endometrial growth or endometriosis. So I would not try and suppress estrogen per se to treat atherosclerosis. I treat the endometriosis and its accompanying inflammation with these agents and make sure I always use some add back to prevent progression of atherosclerosis. So by a little bit of estrogen and eliminating the inflammation is how we're going to keep blood vessels healthy.
Thank you very much. I guess we can call it an evening, at least here in Europe. We've reached our 1 hour and we don't have any further questions. Thank you very much for having you here. Thank you for the excellent overview of the medical therapies. And I think there are a couple of extremely important takeaway messages, like we're not very good in identifying all the superficial lesions, that endometriosis is a systemic disease, and we need to consider that it's not just a local excision of the pelvic endometriosis, but a systemic disease which causes inflammation. And we've got to learn some new interesting aspects about new drugs, about the approach in the US, and I'm sure that all of that is coming slowly to Europe as well, and we'll be having a larger arsenal dealing with endometriosis.
Well,
so
thank you very much for having me. Enjoyed talking with you and hearing all your questions. And I saw some names of some of the people I know, some of my friends out there. So hello to everybody, all my friends in the audience.
Thank you very much. And have a nice evening, everybody, and have a nice day across the ocean.
Thank you.